I'm going to try. My name is Miguel Burch. I'd like to first thank the panelists for the opportunity, as well as SAGES for the opportunity to present my argument for routine intraoperative cholangiogram. So this is my disclosure slide. Also disclosing that prior to COVID, Dr. George Bursey routinely was in my operating room ensuring that I was performing cholangiography. So I have that disclosure. So I want to remind you guys of something that we all did about, variably between 7 and 35 years ago. We had this little thing we did at the end of medical school that was, or maybe the beginning of medical school, that said, first, do no harm. So I say that because I want to focus the discussion on what we're really trying to do here today is protect patients, make sure they have good outcomes after surgery. So intraoperative cholangiogram has variable goals. Among those goals are the prevention of major ductal injuries, identification of injuries at the time of surgery. Those two things help fulfill the previous oath that we just talked about. Also, the identification and management of unsuspected biliary stones, as well as cost savings through prevention of catastrophic injuries and additional procedures. As we know, as my other speakers this morning pointed out, normal, quote unquote, biliary anatomy is in the minority. The majority of biliary anatomy has some sort of anomalous path or takeoff of the cystic duct. That in conjunction with the fact that optical illusions do happen. If I could ask the audience, who sees a triangle here? Yeah, there is no actual triangle here. And so this is the conundrum that we enter into the operating room with, which is conformational bias will make you see triangles by optical illusion. So we already are entering into a setting where only 17% of the anatomy is normal and optical illusions happen. So these are best estimates. Around 750,000 cholecystectomies occur per year. The rate of bile duct injury quoted in the literature is between 1 in 200 and 1 in 400 cases, which with the rough estimate is about 2,500 bile duct injuries per year. Given that, if we were to say X intervention would reduce bile duct injuries by 50%, a power calculation results in a study to actually validly evaluate that technology would require 30,000 subjects. So starting with that, there are no great studies. This is a study that was done by Jenny Sang when she was at the Harvard System, Journal of GI Surgery, where they looked at the inpatient sample during this period of time. They found 111,000 and change cholecystectomies, of which intraoperative cholangiogram was done in about 33% of cases. On average, if you took the number of surgeons who did more than 10 cholecystectomies on average, most general surgeons in that database did 23 cholecystectomies per year. So now that we sort of understand the question, I did a deeper dive back in 2002 to find a meta-analysis that had 40 studies associated with it, which illustrated the bile duct injury rates compared routine versus selective cholangiography. So you see the lower rate there is 0.21. That's with routine cholangiography, 0.43 with selective cholangiography. Obviously a significant difference, almost half the incidence of bile duct injuries with routine cholangiography. But almost more importantly, intraoperative recognition of bile duct injuries when you did routine cholangiography resulted in 87% identification of injury in the operating room when you can still act on the patient and save them from further interventions. Because as we all know, missing a bile duct injury in the operating room results in a pretty poor prognosis post-operatively. So that was 2002. So in 2021, there was a Scandinavian meta-analysis which involved 2 million patients. Interestingly, from 2002 to 2021, the bile duct injury rate did not drop that much, but again, those who do routine cholangiography have a lower rate of ductal injury. And in the same paper, there was a Swedish analysis of routine intraoperative cholangiography versus selective in terms of time, and that's one of the arguments is it slows you down in the OR. Routine cholangiography took 12 minutes, selective took 25. So there is an impact in terms of operative time, but by comparison with the impact on saving people's injury, I think that might be something we talk about later. Another study from Europe looked at how often we can find CBD stones when we do cholangiography. And so you can see here that routine intraoperative cholangiogram detected stones in around 5% of patients versus 1% in selective cholangiography. How those stones were then managed was also interesting. If you just did a cholangiogram, you obviously found stones and you could act on them at a surprisingly low rate of 2.8%. So they were only able to act on those stones because of at around 2.8% of the time versus doing ERCP, which my previous discussants have talked about the advantages and disadvantages of. So maybe the next thing we should talk about, and it's already been discussed, is why we aren't training people enough to do intraoperative cholangiogram and laparoscopic duct explorations. So in terms of efficiency, nothing is quite as efficient as doing all the things in one setting. So in our hospital, if somebody comes to the ER, they get an MRCP the next day usually, the day after that an ERCP, maybe an operation and maybe discharge versus ER to operation to discharge in a much shorter period of time. And routine intraoperative cholangiogram is cost effective, particularly if you compare that to the cost of bile duct injury, both in terms of the cost to the healthcare system, as you can see here, but also in terms of the cost to each individual surgeon's litigation cost. Previous discussants have already talked about the high likelihood of patient judgment in the side of the plaintiff for most of these cases. So the tension exists between first do no harm and being cost effective. That's really the only argument I can see for not doing routine cholangiogram. But let me help you. First do no harm, be cost effective. IFC is the balance of those two tensions. If you do routine intraoperative cholangiogram, your rate of major bile duct injury will be halved. You'll add 12 minutes to your operation at very low cost over yours and the patient's lifetime. Routine intraoperative cholangiogram is the standard of care in Sweden, but what do they know about safety or efficiency? They have when routine intraoperative cholangiogram became standard of care, they saw a 29% decrease in their rate of common bile duct expiration. Interestingly, if a patient has bile duct injury in that system, because it's usually detected in the operating room, the mortality rate you can see there is much lower than if it's found later, resulting in a reduction of death of almost 62% for those patients who have their bile duct injury identified in the operating room. I thought to myself, what else reduces mortality that much? Well, the CDC says seatbelts. Seatbelts don't prevent accidents, but when used routinely, they reduce death by 45%. So for my challengers, I would like to propose a test. I will routinely use my seatbelt. If you guys selectively use your seatbelts, and you think it might be a riskier day. So in conclusion, routine intraoperative cholangiogram provides indirect benefits. It helps us educate residents, familiar support staff, so they become more efficient, gaining experience for more difficult cases, and allows us a pathway to more complex interventions. Thank you very much for your time.